Are you struggling to make sense of the heart and the cardiac silhouette on a portable chest X-ray? Can you recognize which chamber may be the problem by simply looking at the cardiac silhouette on a chest X-ray? In this video, Heart Borders and Chambers on a Chest X-ray Made Easy, I'm going to show you exactly how to read a real heart X-ray image, identify those heart borders, and quickly spot chest X-ray chambers for solid chest X-ray interpretation. So whether you're still in training or you just need a review of the radiology basics, let's simplify heart borders and chambers together. Hey guys, I'm Dr. Busti and welcome to another topic review at This Is Why, a show that helps healthcare professionals transform their medical knowledge from not just knowing the what, facts, right, but understanding the why, so that what we do every day in clinical practice and in patient care makes sense. You don't have to memorize it anymore. All right, guys, let's go ahead and get started. Step one, we need to confirm the projection. AP versus PA. Is it well inspired, got good inspiratory effort? And is the patient non-rotated? That's what we want, okay? This is part of the RIPE mnemonic that I use in my own clinical practice, but I also teach about it in my other lectures to determine chest X-ray image quality. Now, the RIPE mnemonic should be considered every time you open a new chest X-ray. And if you want a full review on how to use RIPE and the A through I mnemonic when reading a chest X-ray, check out my video on how to read a chest X-ray like a pro. Why does this stuff matter? Because there is literally no point in interpreting a chest X-ray that's either done wrong or that is of poor diagnostic quality. Now let's pause for a minute and take a little bit of a closer look at a heart model so that we can tie it into the chest X-ray image that we're going to look at a little bit later. One of the things that I wanted you to get an appreciation of is, again, one of the reasons why we study basic and normal anatomy, in school, or you go into gross anatomy for medical school, those kind of things, is so you understand its orientation in the normal body and its space, okay? You can see here that this is the basic orientation of how the heart literally sits in the chest. And so the shadow that is casted once the X-ray beams go through the chest wall and hit the detector plate, it creates an outline. So you need to keep this in mind. But also the parts that are exposed in the front part of the chest, which is why I'm holding it this way, you can see the aortic arch coming out and around, and go behind the heart and down, right? The pulmonary artery. But the most anterior portion of the heart is actually the right ventricle. Over here on the right side of my body, right, is the right atrium. You have obviously the superior vena cava, SVC, but then down here you have the inferior vena cava. Now you're not always going to see those clearly, but there are little bumps. But if this bows out or it changes its shape on the cardiac silhouette on the heart image on the X-ray, that's telling you something. That's orientation is pointing to this anatomical component. Same thing over here. You're mostly seeing on the chest X-ray, which we'll see in a second, the right ventricle. That doesn't mean that you're not seeing any of the left ventricle, but you can't see the septum here, but it's right here. And this is the apex of the heart, which you also see in the cardiac silhouette. But you also see that most of the portion of the left atrium is going to be, and the left ventricle are behind there, but the left atrial appendage is just right below the pulmonary artery going out, obviously to the lungs. So this is important. And then if you were to remove, obviously, the inside here, trying to visualize in layers what you are learning and what you're applying to. So let's now take this model and this imagery, and I'll utilize some other images, and let's now integrate it with the image on the X-ray itself. That really makes it come alive and puts something in our minds that we should be looking for, okay? So what you see here is the lungs with the great vessels and the heart in their normal anatomical position and orientation. It's important to see that the heart is sitting inside and that the lung slightly wraps around the heart. But again, the most anterior portion of the heart is the right ventricle. Your right atrium is over here, okay? The left ventricle portion is over here, and then of course the apex is sitting in this area right here. But if you were to take that and now put that over into that chest X-ray, those are some of the things that you're seeing, even including some of the vascular markings that are there. Now if we remove the lungs and we just look at the heart anatomy, again we have the right atrium over here. We have, again, the majority of the right ventricle on the most anterior portion of the thoracic cavity, and then in the lateral aspect on the left side of the patient is the left ventricle forming the apex down here. But you can see that so there's the aorta, but then there's the pulmonary artery also coming off, but that the left atrium is really kind of tucked in back behind there. So we don't see it like we do a little bit of the right atrium. So that becomes relevant if you start to see the borders shift and change, and you have a good quality image that is appropriate aligned with appropriate inspiration and visibility, right? Now let's take those images and let's now merge them together, okay? So here you can now see the image kind of overlaid or integrated in what you should be visualizing in your mind. What are those anatomical markings and locations that make sense of the borders and the chambers that we're looking at? That's the point of this topic review, is so that you could say, oh, okay, I think that curve or that formation right there is probably this portion of the heart or the vessels associated with the heart. So now we move on to step 2. Okay, this is now, step 1 was you determined that the image quality was appropriate. It's appropriate to interpret. Step 2 is now let's start, and most people tend to trace the right side or the right border first. Now remember, this is the right side of the patient, and this is their left side. So you got to keep yourself oriented to their anatomical positioning. So the right side, if you're looking at it, you're going to see the superior vena cava at the top, and that's this area right here. Okay. As you come down, you're going to see a portion of the right atrium and that portion of the right, and that forms the right-sided costocardiac angle. Okay. That should be sharp, should not be blunted, nothing should be occupying it. We'll see some examples in just a few minutes of what looks abnormal and how that cardiac silhouette and the borders get distorted so that you understand why. On the left side, you can see the aortic knob up here. And then there's the pulmonary artery coming out, likely right there. And remember, the left atrium is typically tucked in and around in a more posterior area. But it would, typically start to fall in this area, and that's sometimes where you see the left atrial appendage on some patients. And then, of course, the left ventricle forming the apex down here, and if you kind of connect all the dots. But remember, the right ventricle is the most anterior portion that you're seeing here in this portion of the chest X-ray. This portion over here represents typically that left ventricle, okay? Now some of you may be asking, why did you not cover the cardiothoracic ratio or the CTR? And you're right to consider that in this when we talk about the cardiac silhouette, because what you are considering is this width right here compared to this width. But remember, that should predominantly only be done on a posterior anterior radiographic image. When you're using a portable chest X-ray, the risk of the heart being slightly enlarged due to the deflection of the X-ray beams before they hit to the detector plate is at greater risk of doing that with an AP view. So if there's any concern, which on this case there's no concern, PA is going to be even potentially smaller or more precise, but it's not going to be larger than this. So if you do see, however, cardiomegaly or the cardiothoracic ratio exceed 0.5 or make up more than 50% of this, right, then you would consider doing a PA to reevaluate the heart silhouette or some other imaging modality like an echocardiogram, okay? All right, so I suspect you're like, man, that's great, but what does it look like when it's abnormal? And so I have a couple images just to compare some of the different pathologies that we see in real-world clinical practice so that this makes sense and why you're learning the normal when you're comparing it to abnormal. And so you can see here on this first one, this is actually a patient who had traumatic chest injury. You can see many rib fractures here. Again, that's the importance of following them around. You also see something external going in with some markings here. That's a chest tube. So this patient had a traumatic pneumothorax with a collapsed lung and a placement of a chest tube. But look at the cardiac silhouette. The borders are lost on the left side. It's just patchy, hazy. There's fluid there, could be infected, could be blood there, especially being traumatic. And so you can see that the heart border. Now look over here, you also see that the patient is not aligned correctly. And so that makes the mediastinum look weird. It extends out the right side here, but if you look here, these are your thoracic spine, and here's your left clavicular head versus the other ones we over here. So the patient in this image is actually rotated. Now, they may not be able to do anything different because they're in the ICU or something like that, or they're in the hospital, and they can't position themselves perfectly, or they can't stand up because of other traumatic injuries that would allow a better image. So you have to work sometimes with what you got, but at least you can see that some of that distortion of the cardiac silhouette, especially on the right side, is partially influenced because the patient is rotated. These are some examples of patients with pneumonia, and again, you can see that the costocardiac angle starts to get less clear. You can see more haziness and opacities in this area that distorts the right atrium and that portion of the right ventricle that's down there at the base. Again, you can see what infiltrates will do, masses will do to the cardiac silhouette. This is a patient with a pretty significant fluid accumulation, so pulmonary edema, effusion, again distorting that heart cardiac silhouette, mainly that left ventricle in the apex. I don't know where it's at. I drew that line there, but I can't really say that for a fact that that's what it was, but that's just kind of where it was supposed to be, right? You also see that this does look like a fairly good midline. Clavicular heads seem to be equal, and there's some bowing out here. What's going on there? So again, this patient, something pushing on them, pushing the heart over, right? Fluid, a mass, or something else pushing on that. Also could be causing changes in the intracardiac pressures that are bowing out on that right atrium and some of the portion of the right ventricle. This is a patient over here on the right that has had open heart surgery. You can see obviously the thoracic wires here. You can even see something here, looks probably a valvular replacement. But look at the cardiac silhouette. I mean, it's very hazy and enlarged, distorted. It's hard to fully see where the borders are in this patient who probably has obvious heart disease, likely experiencing some degree of heart failure. And this is another, again, not aligned patient. You know that because, again, you can see the thoracic spine versus the trachea over here. Here's the clavicular head. They're not equal distance, so the patient is rotated. that is shifting the mediastinum. Now there's also some other things going on here. This patient also has an aortic aneurysm, but you can see that it's no longer looking normal as compared to this. And again, that's why it's important to understand RIPE, your image acquisition, the quality, before you make assessments. And if you still make an assessment and it raises concern, then may lead you to going to the next imaging modality to fully ascertain what might be going on, especially if the patient is presenting with a number of symptoms and findings that would be consistent with a certain type of diagnosis that would be of concern to you. So I hope you found that to be helpful. I always find that integrating the abnormal into the normal really gives me that big picture of why am I learning this? Why do I need to acquire the skill set of properly assessing a chest radiograph and the value of what does normal look like? So you can't discern the abnormal if you don't know the normal, and it just requires you to do repetition. So don't be afraid of some of this stuff. Don't get overwhelmed by this stuff. Tackle it, approach it, but use a systematic approach to doing it. And that's why I cover the RIPE mnemonic and use the A to I mnemonic to guide me. So I hope you found this to be helpful. Please subscribe to us on our channel on YouTube, and also give us a like if you don't mind. That really helps us out a lot in to be able to produce this kind of free content for you guys. Lastly, if you want to see this put in the context of the overall reading of a chest radiograph, check out my review on how to read a chest x-ray like a pro. Okay guys, thanks so much for joining us. We'll see you next time. Take care.